It begins at the base of your skull on one side, always the same side, a deep, boring ache under the occiput that climbs over the back of your head, wraps the temple, and settles behind the eye. Turning to check a blind spot sets it off. Sleeping wrong sets it off for 2 days. You have been told it is migraine. You have been through triptans, preventives, a neurologist, a normal brain MRI, a shrug. I am an interventional pain physician in St. Louis at the Padda Institute Center for Interventional Pain Management. Something should have been said at your first visit. Head pain that starts in the neck is not a variant of migraine. It is a different problem, diagnosed a different way. Here is what happened to you. Headache is coded as a brain problem, routed to a brain algorithm with no step that says examine the upper neck. Nobody palpated your C2 to 3 joint. Nobody tested whether rotation to the painful side reproduced your headache. Nobody asked about a rear-end collision or a fall. And critically, nobody ever performed the test that interrogates the source directly, a targeted, image-guided anesthetic block of the nerve under suspicion. It is not infallible. Barnsley and Bogduck showed in the Clinical Journal of Pain in 1993 that a single uncontrolled cervical block is falsely positive roughly 27% of the time. That is precisely why one block is never enough, and it is also why the block still has to be done. That is what a 15-minute headache slot cannot do, a differential that takes an examination and a procedure to resolve. You do not need a fourth preventive. You need to know whether the pain is coming from your C2 to 3 joint. The anatomy explains this. The sensory fibers of the first 3 cervical nerves enter the upper cervical dorsal horn, which is continuous with the descending trigeminal nucleus. The relay that carries sensation from your face, your eye, your forehead. Cervical and trigeminal afferents converge onto shared second-order neurons in that trigeminocervical nucleus. That convergence, supported by animal electrophysiology and human referral mapping, best explains why an irritated structure at the back of your neck produces pain at the orbit, temple, and vertex. Consider what feeds that line. The greater occipital nerve from the C2 dorsal ramus, the lesser occipital nerve from the cervical plexus. The third occipital nerve, the superficial medial branch of the C3 dorsal ramus, which crosses the lateral C2 to 3 facet joint and innervates it, and that joint itself, a recognized source of headache after whiplash. Symptoms alone cannot tell them apart. First, the dangerous causes must be excluded. A new, abrupt, or thunderclap headache is not a pain clinic problem. Neither is headache with neurologic deficit, fever, jaw claudication, vision loss, scalp tenderness in an older patient, or cord compression signs. Dissection, myelopathy, and giant cell arteritis are evaluated urgently, not injected. Then the differential begins. Occipital neuralgia is a nerve problem, lancinating, electric, following the distribution of the greater, lesser, or third occipital nerve, most commonly the greater, often with a tender point where the nerve pierces the fascia, and frequently with altered sensation in that patch of scalp. Cervicogenic headache is a referral problem, pain generated by a cervical structure and felt in the head. Most often that structure is the C2 to 3 joint, but it can be the disc, the deep muscle, or the occipital nerve itself. It presents as a steadier, side-locked ache provoked by neck position and movement, with restricted rotation on examination. Migraine has its own signature: nausea, photophobia, phonophobia, throbbing, family history. They overlap because they share that nucleus, so history and examination narrow the field without closing it. The test that comes closest to an answer is anesthetic, not radiographic, and only when it is repeated under control. Here's what we do differently. We use a diagnostic block as a question, not as a treatment. A small volume of local anesthetic goes onto one named target under image guidance, ultrasound for the occipital nerves, fluoroscopy for the third occipital nerve and cervical medial branches, and we measure what your headache does over that anesthetic's known duration. Then, skipped almost everywhere, we repeat it as a controlled comparative block with an agent of different duration. Concordant relief on 2 blocks, not enthusiasm after 1. The multi-specialty consensus guidelines from Hurley and colleagues in regional anesthesia and pain medicine in 2022 on cervical facet joint pain favor medial branch blocks over intra-articular injection as the more predictive test. A plain local anesthetic block lasts hours to a day or two. Its value is informational. Adding corticosteroid may extend relief to weeks in some patients on weaker evidence, and that use is off-label. No injected medication carries FDA approval for occipital neuralgia or cervicogenic headache. Now the evidence at weight. Naja and colleagues in pain practice in 2006 ran a double-blind, saline-controlled randomized trial in cervicogenic headache with 47 patients analyzed. Nerve stimulator guided occipital blockade reduced pain scores roughly 50% from baseline and cut analgesic consumption significantly more than saline. 3 qualifications, and every one of them matters. Follow-up was only 2 weeks, so that trial tells you nothing about durable relief. The injectate was bupivacaine, lidocaine, clonidine, and fentanyl. The clonidine and the fentanyl are off-label for peripheral nerve blockade. And because of that mixture, this trial does not validate the plain local anesthetic block or the anesthetic plus steroid block that you will actually be offered. It is the best randomized signal that exists here. It is not a result you should expect to be handed. If comparative blocks confirm a third occipital source, neurotomy becomes a reasonable discussion. Govind, King, Bailey, and Bogduk reported in the Journal of Neurology, Neurosurgery, and Psychiatry in 2003 that 43 of 49 patients met a hard endpoint, complete relief for at least 90 days, normal daily activities restored, and no headache medication at all, with a median duration of 297 days. That is a single-center, open-label, uncontrolled series from the group that developed the technique in patients selected by controlled comparative blocks. There is no sham-controlled trial. I will not inflate it. The effects are real. Unsteadiness and ataxia in most patients, scalp numbness in about half, painful post-neurotomy neuralgia in a minority, plus bleeding, infection, vasovagal reaction, allergic reaction, intravascular injection with local anesthetic toxicity, and no relief at all. With steroid, add elevated blood sugar, hair loss, skin thinning, or depigmentation at the injection site. The nerve regenerates. Relief is durable, not permanent. That is not the end of it. In that same series, 14 patients had the neurotomy repeated when the nerve grew back. 12 regained relief, with a median of 217 days. So the honest shape of this is a repeatable window, not a one-time cure, and not a single throw of the dice. And while we are being exact about evidence, ketogenic nutrition, specialized pro-resolving mediators, and red and near-infrared photobiomodulation remain adjunctive and emerging for this condition, with largely preclinical mechanisms and no controlled human outcome data in occipital neuralgia or cervicogenic headache. Support, never the answer. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. Consider someone rear-ended, recovered from the obvious injuries, left months later with right-sided headache from occiput to eye, 4 years of migraine treatment, normal imaging. On examination, rotation right is limited and reproduces the headache, with tenderness over the C2 to 3 joint. A fluoroscopically guided third occipital nerve block abolishes the headache for the anesthetic's duration. A comparative block weeks later, different agent does the same. Only then is neurotomy offered. The first weeks are genuinely unpleasant. The world tilts when they walk, a patch of scalp feels like leather, and someone else drives. The neck still has to be rehabilitated, deep cervical flexor endurance, scapular control, postural work. Sleep, glycemic control, and inflammatory load are worth attending to in anyone carrying chronic pain. But I will not tell you they drive this particular headache, because I do not have the data to say so. Somewhere in the 3rd month, the headache stops being the first thing they think about. Not gone, not first. If your headache is one-sided, starts below the skull, and moves with your neck, ask for the differential you were never given. Ask whether a diagnostic block is appropriate, and insist any ablation be preceded by 2 concordant blocks, not 1. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Full detail is at painmd.tv. Stop letting migraine be the answer by default. Find out what your neck is doing. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.